will start the next session. It's going to be focused in myeloma and lymphoma. So our first speaker is a dear colleague and friend, Dr. Saud Alhayli. He's a consultant hematologist at the lymphoma and myeloma section at Department of Hematology, King Faisal, a specialist hospital in Riyadh. Welcome, Dr. Saud. He will talk about CAR-T role in the management of multiple myeloma.
Should we start? Should we wait a few minutes?
No, you can start.
So I would like first to thank the organizing committee for their kind invitation, the audience for their kind attendance and staying for the myeloma session. So my talk gonna be about CAR-T cell in multiple myeloma, approval, where it fits, which line of therapy, some toxicity with this treatment. So, you know, there are so many novel agents has been approved for multiple myeloma that give you and your patients a lot of option trying to shuffle, you know, between lines of therapy, between medication that they have been exposed to. And, you know, the 2016 years was named the year of myeloma because of 3-4 medication has been approved for those patients. And, you know, first line of therapy has been now almost standardized for transplant eligible, usually DARA VRD and or isatuximab VRD, and for those transplant ineligible, you know, it used to be DARA Revlimid Dix, and you know, Mayo Clinic on their MSmart last week, they have updated their guideline. They're also including DARA VRD based on recently conference that showed it has been efficacy for those patients who are transplant ineligible. Problem comes when they start to have first and second and third and fourth relapse. You're really gonna run out of your options and of your medication. And if you see as you go from second to third and fourth line, you don't only lose your response rate, you only lose your CR rate. So you, with third and fourth line of therapy, you barely get 3-4% of CR rate. So basically, you're gonna tell your patients, whatever medication I'm gonna give you, usually you will have a few months of response, and you're usually gonna live around 6 to 9 months. And this has been also published in multiple retrospective analysis and showed when you became a triple refractory, the patient become a triple refractory, basically any medication you gonna give them few months of response, and then you start the talk with your patients, that's usually your median survival less than 9 months. So this is really a problem because patient will run out of hope. They will start, you know, looking for any alternative therapy. You don't have any options. All of those novel agents, when they are used in combination, gives you, you know, around 30 to 40% of response rate, nearly 2-4% of CR rate. And that response gonna, you know, last a few months, and usually half of the patient there usually did because of disease progression by 6 to 9 months. With new agents that we have selinexor. However, selinexor is very effective if you use it earlier and has been approved with selinexor Velcade Dix. Gives you a longer PFS. However, we're gonna use in third, fourth, and fifth line of therapy with dexamethasone because usually those patients are triple refractory. Usually the median PFS is less than 4 months. Belantamab, we unfortunately has been withdrawn from the market by the FDA. Melflufen as well. So you really, despite all of those novel agents, all of those, you know, medication available, when you come to third and fourth line of therapy, you have no option, and those options usually they don't last longer. So we really need a new target. We need to tell your patient we have a new medication for you that's gonna give you a high response rate, high CR rate, longer PFS, and you're gonna live more than 6 or 9 months of therapy. And this comes with the BCMA, B-cell maturation antigen. It's rarely expressed in lymph nodes and heavily expressed in the multiple myeloma cells. It's has been shown to cause a lot of cell growth, resistant to treatment, and immunosuppression to bone marrow microenvironment. My focus today is going to be on CAR T-cell rather than bispecific. We'll have a later talk by Dr. Ghazi about bispecific in the treatment of multiple myeloma. You know, the CAR T-cell, we know the first generation when it comes in 1990s and 2000s showed some response, however, was not durable. Then the second generation, when they added another co-stimulation domain, and most of the CAR T-cell available in the market are second generation CAR T-cell. Third generation, they tried, they said, once we add another co-stimulation with second generation, maybe if you add additional co-stimulation, you're going to get more and more effects. However, that led to more of B-cell eradication, high risk of infection. So maybe that's why it was not advanced in the market. Fourth generation, it's been designed, in addition to hematological malignancy, also solid tumor. Fifth generation, they have the ability to switch on and off for, but all is still under clinical trial. You're all familiar with this. You need to collect T-cell, then you send it, and this is the only problem with your CAR T-cell, is you need to wait, 8 to 10 weeks before you start your next therapy. So we're gonna examine all CAR T-cell that has been approved, and we'll see where you can fit them in the treatment of multiple myeloma. So the first CAR T-cell was the B2121, was presented by Nubur Raji from Dana-Farber, and it showed, if you see here, they have the BCMA targeted therapy, they have transcellular domain, T-cell activation, and intracellular domain. So for the first time, we're away from less response rate, minimal duration of response. They started phase 1 where they have different targeted dosing, started from 50 million, 150, and more than 150 million. And for the first time, we see in those relapse refractory setting, you have treatments that give you very high response rate of around 90%, and CR rate, not 3-4%, it's almost 40%. And this was translated into PFS of around 1 year for those who receive more than 150 million. And those who achieve CR, the 40%, their median PFS of around 18 months. So for the first time, we have a single treatment that gives you high response rate, deeper response of more CR rates, and longer PFS away from 3 to 4 months. And those patients, it's not gonna, their disease gonna be controlled, they're gonna live longer because of control. And this led to the phase 2 trial of, they said, since we have the more than 150 million gives us the best response rate, so we're gonna examine different dosing of 150, 300, and 450 million. And if you see the baseline characteristic, it's similar to what you see in your clinic, 1/3 high risk, their median prior line of 6 for those patients. And if you see those who receive 450 million, they have the best response of around 82% with 40% CR rate for those patients. And this, on heavily pretreated patient, you have median PFS of around 9 months and median overall survival of around 20 months. So again, so now we start to be away from the talk that's usually you're gonna live for 6 months. Now we're talking about 1 to 2 years of disease control and median overall survival of around 20 months. And if you see those who receive the higher dose of 450, they have median PFS of 1 year. And if you achieve CR, those 40%, they have, that's response would last for around 2 years. So after this phase 2 trial, this led to the FDA approved in 2021 for the first CAR T-cell in myeloma to be used on the 5th line, and usually you have median PFS of around 9 months and better than your conventional therapy. And once, now similar to all other therapy and all other site of malignancy, once you approve your medication on the later line, you try to advance it, and this led to the phase 3, the KARMA study, which usually against your novel therapy, triple combination of what you used to give for your patient of multiple myeloma. It was 2-to-1 randomization against Darabom-Dex, Daravilcade-Dex, Ixazomib-Revlimid-Dex, Carfilzomib-Dex. So this is what you usually give for your patient on 2nd, 3rd, and 4th relapse. And if you see 90% they're IMiD refractory, 95% they're Dara refractory, and 75% there are Velcade or Bortezomib refractory, proteasome inhibitor refractory. And again, this is what we expect with your novel agent when you use it later, give your median PFS of around 4 to 5 months. And if you see, it showed a better PFS of around 13 months compared to 4.4 months for conventional therapy, triplet therapy for patients with relapsed refractory multiple myeloma. And this is, again, why the longer PFS usually comes from high response rate and high CR rate. Instead of 5%, you have almost 40% of CR rates. And what about toxicity? You know, cytopenia is toxicity, but usually, you know, doesn't last for a long. Grade 3 and 4 is still around 50–60%, but usually they resolve within 3 months. You still have some hypophosphatemia and hypokalemia for those patients. And after this phase 3 trial, now you can use this Idacil in earlier line. It's approved after 2 lines or more, so you can use it on your 3rd line, and you're expecting BFS of 13 months. So we know when you use it in median of 4 to 5 lines of therapy, you have median PFS of around 8.8. If you use it earlier, after 2nd line, you have around 13 months of median PFS, and that's better what you expect with your conventional novel agent triplet therapy. Is there other CAR T cell? Yes. You know, the Chinese, they have different CAR T cell, the Legend company. They have now 2 targeted BCMA therapy, and this is, they claim that it has better affinity, better, improvement in the patient response rate. And they have this, they have phase 1 trial where they use their CAR T cell and led to impressive. Now, you see on those heavily pretreated patients, you have, for the first time, median PFS of around 20 months. So we're now moving away from 4 to 5 months of median PFS to 20 months for single treatment, and usually those, patients, 30-year median overall survival of 60%, give you median overall survival of 3 years. That's really impressive compared to what you have in your used to give for your triplet therapy for relapsed refractory multiple myeloma. Then Janssen took over the company because of this impressive result, and they started their phase 1 trial. Basically, they have fixed dosing, different than Idacil, where they started with different dosing. Now they have 0.75 million per kg CAR T cell, and if you see impressive overall response rate of almost 100%, CR rate of 80%, and give you median PFS of almost 2 years. So this treatment is really a new change or game change for patients with relapsed refractory multiple myeloma. For the first time, we're seeing a treatment, if you use it later on, where you don't expect to have any response or minimal response, and that response will last for a few months. Now we're talking about 2 years of median PFS. And even if you were able to achieve MRD negativity by 6 months or 1 year, none of those patients died in the coming 2 years. And if you're able to sustain your MRD for your patient for more than 1 year, none of those progress in 2 years. Toxicity similar to any CAR T cell in lymphoma, leukemia, cytopenia, some ICANS, some CRS. However, we start seeing some neurotoxicity in patients treated with cilta-cel, and we'll see later on what kind of neurotoxicity they will have. So after this impressive around 20 months of median PFS, in 2022, it has been approved for 4 or more lines of therapy, so you can use it on your 5th line of therapy for patients with multiple myeloma. So once you have shown an efficacy in your later line, then you try to advance it. So they start to design the CARTITUDE, different cohorts. Cohort A is what you see in usually 2nd line of therapy. They said, let's do phase 2 for 2nd line of therapy and see the effect. Cohort B, I think those are the most patients that will benefit more or most from CAR T cell therapy. Those who usually, we say conventional high risk, they relapse less than 1 year from your transplant. And cohort C usually relapse refractory setting. Cohort D less than CR and auto transplant. E is high risk patient, F are standard risk multiple myeloma. If you see cohort A in second line showed almost 95% response rate, CR more than 80%, similar toxicity. We start to see some neurotoxicity different from other CAR T cell. We're starting seeing some nerve palsy. We're starting to see some Parkinsonism when you start using those CAR T cell therapy. And the press release, people start wondering why we have this kind of toxicity. Mount Sinai Hospital, they have some autopsy done on 2 patients, and they found some BCMA in the caudate nucleus, and basically that was, drive some more neurotoxicity. However, around 10 to 15%, they're grade 1 or 2, around 5% grade 3. We have a patient who participated in the CARTITUDE-2. He had facial nerve palsy, 6 nerve palsy. They're all recovered in around 2 to 3 weeks. Then he had some mild Parkinsonism. He was treated with some steroids, some IVIG, and he has made almost full recovery. He is now more than 1 year, and he's still MRD negative. So maybe if this treatment used earlier, we're talking about cure. We don't know, longer follow-up is needed. And if you see 30-month PFS is 75%, 30-month overall survival is the same, 75%. So if you use it earlier, you get even a better result. So this is based on this phase 2. In second line of therapy, they said, let's try to do phase 3 and see, is this gonna show the similar efficacy or not? We're moving to cohort B. Those are high risk by conventional. They are not high risk by ISS. They are not high risk by cytogenetics or FISH. They usually relapse less than 1 year. And within 2 years, maximum 3 years, you use 3 or 4 lines of therapy for those patients. You really struggle to get them into deeper response. And their median overall survival less than 2 years. So really you need some treatment change for those patients, because usually you're gonna lose them faster compared to other patients.
You have 2 minutes.
Okay. So when CAR T cell was used for those patients, it showed almost 100% response rate, very deep CR, similar toxicity. And if you see 1 year PFS 90%, 2 year PFS 73%, and overall survival 2 years is 84% compared to less than 50% for those patients. We're going to talk about phase 3. If you see this compared to Bomvelcade-Dex, Darabom-Dex, and if you see the 12-month initial report showed 1 year, and this is what you expect with Darabom-Dex, give you a median PFS of 1 year. And if you see longer follow-up, showed a median PFS of around 3 years. So for the first time, you have a treatment that gives you median PFS of 3 years. And for the first time, this treatment showed not only PFS advantage and overall survival advantage for those patients. And if you see all subgroup analysis, they benefit, whether they're high risk, low risk, age, extramedullary disease, they benefit. If you use it first line, after 1 prior line or 2 or 3 lines, it has similar efficacy and MRD negativity at least 3 times compared to your conventional therapy. We know always when you advance treatment from phase 2 to phase 3, you see different, sometimes disappointing result. However, it was across all phases of therapy. Toxicity we talk about, some peripheral neuropathy, cranial nerve palsy, and some Parkinsonism, but usually grade 3 and 4 is around 5%. So after this, Cilta-cel has been approved for second line of therapy, and you expect to have PFS of 3 years. So myeloma, they always try to complicate your life. So they are now testing it against conventional VRD therapy for transplant ineligible, and against auto transplant for transplant eligible patients. So maybe in the coming few years, your all treatment modality is going to be different for those patients. So just to summarize, if you have your first relapse, you can use triplet therapy. However, if you use your CAR T cell, it showed PFS and overall survival advantage. That based on the CARTITUDE-4. If you don't have that option, then or you wait for the second relapse, you have other option is ide-cel based on the KARMA showed PFS advantage, gives you around 13 months. If you have a patient who is a relapse refractory on your 4th or 5th line of therapy, you can use both, but you expect lower PFS of around 8 to 9 months in Idacil and around 19 months in Cartitude. I don't know if we have other still Ovacil, another BCMA therapy is still not advanced, maybe because some neurotoxicity and infection. If you want to compare all of those, you know, Karma gives you median PFS of around 8 to 9 months, Cartitude around 3 years. Most of those patients, they will require some steroid and tocilizumab or anakinra because of some CRS. You expect to have more neurotoxicity, especially with cilta-cel in form of nerve palsy. And I think I will stop here because of the time. Thank you.
Thank you, Dr. Saud. Thank you, Dr. Saud.